Good morning, good morning. It's Jennifer Gibson. I'm coming to you live from Axxess headquarters in Dallas, Texas. I'm here to help us get through some of the questions that we might have with the home health conditions of participation and how they apply to our agency core upgrades. Those of you that have been with me before know that I'm a registered nurse. I've been in home health since November of 1993, following a stint in the hospital as a med-surg urology nurse. And I've now really enjoy helping the industry and helping those of us that serve patients in the home. So what I want to do today, we're going to go through the home health conditions of participation as a kind of a selected parts overview. I want really for us to focus on those parts of the conditions of participation that have caused functionality changes in our agency core product so that you understand the whys as to the changes that we've made. And then following this webinar this afternoon at 3 o'clock Central Time, my colleague and friend Ms. Shawn Hamilton here will be doing the functionality piece and overview of how the agency core product is working with the changes that we've made. So make sure that you attend both of these sessions if you haven't had the opportunity before, and also know that these sessions are also recorded and placed in multiple areas in the agency core software. They will be on the on-demand training videos section, as well as archived in our help center within the next few days. Also want to encourage you, if you're listening today and you have questions regarding the conditions of participation standards themselves, if you will click on your GoToWebinar toolbox by clicking on the little orange arrow and opening that up, you'll see a tab that says questions, and if you will put your questions in there, we will be monitoring those during the webinar today and answering as many of those as we can during our session. So let's go ahead and get started this morning. I just wanted to give you an opportunity here to realize that the slides, once you receive these, by the way, they will be coming in the next couple days to the email address that you used to register for this webinar. Once you get these slides, just remember that the slides themselves are just meant to be cue points, and so everything that there is to know about the conditions of participation will not be in the slides, nor will they be in this presentation. Just wanted to make sure that you understand that. Oh wow, that is a very broad question. Right at the beginning here we've got, what is the best way to prove to CMS and the surveyors that you are meeting the COP requirements? And the best short answer I can give you for that, it's all about documentation. Your documentation is really where the rubber meets the road as to whether or not you're doing this. But when your surveyors come in, they're going to be looking at chart reviews. They're going to be looking at the patient's home folders. They're also going to be conducting interviews with the staff, whether that be administrators or field staff or both. So that's where a lot of the education that we're going to get into later in this webinar comes in. There are certain things in the COP standards that we have to meet as far as educating our staff. And so you want to make sure that your staff are well educated and well versed on the changes that you've made to your policies, but also to the functionality and what you're doing there at your agency. Okay, so good question right off the bat. Thank you. Let's get right into some of the new regulations. Again, these are just going to be parts of the regulation that affect the functionality in our system. We want to really give you a heads up as to why we've made certain changes in our agency core product. We're going to talk a little bit about patient rights first off the bat. Then we're going to get into the content of the comprehensive assessment, and that's a biggie. Then the plan of care. That's also going to be kind of a big issue. Coordination of care, written information to the patient, infection prevention and control, and we're going to talk about what the expectations are for the skilled professionals in home health as well. I'm not going to spend an awful lot of time on this slide with notification of patient rights. Most of us are pretty in tune with what we're supposed to do with notification of patient rights, but I do want to highlight some timelines that are a little bit different and let you know that there are several additional people that have to be notified of rights and how they're to be notified. You've got patient notification to think about, you've got legal representative notification to think about, and then a new patient chosen representative as well. Most of us are accustomed to notifying the patient of their rights in written form before care is initiated. That's nothing new. What is new is the legal representative, if they have one. That would be like a power of attorney. Those persons also have to be notified in written form of the patient's rights before care is initiated, and that's going to cause you to have to do some coordination of care. Most of us probably already do that now, but this needs to be documented, as the first question just asked. How do you prove you're doing this to the surveyor? It's all about your documentation. So you're going to want to find out who this person's legal representative is as early as possible, and make sure that that's well documented and that you've contacted that person to let them know that you're going to be doing a patient admission or an assessment, and finding out whether or not they can be there and how to get them their copy of patient rights. For that reason, we have included in your new patient form or your referral form the ability to document who that legal representative is, as well as what you've done as far as contacting them in regard to this admission and assessment. So just know, I like to emphasize this over and over. We are not just sitting here putting in boxes at agency court to make your life miserable. We're doing this to help you be able to document easily and timely so that you can prove to the surveyors and to CMS that you're following their guidance. We also see that the patient-chosen representative, which can be a neighbor or a friend or a caregiver, paid help, whomever, that patient chooses as their representative, in addition to legal representatives, they also have to receive a written copy of the patient rights within 4 business days. And that 4 business days timeline counts from the initial assessment date. Now, one thing that's clarified in the draft interpretive guidance is that written means literally that a hard copy, written copy, is given to these persons unless they specifically ask for an electronic copy. Now, I've had several questions asking about a patient portal, and are we going to put a patient portal into our system? That may be coming down the line at some point, but for now, because most of our patients are going to choose the written form of notification, we haven't done that patient portal just yet, because we don't want agencies to believe that they can just load all this in the patient portal and be okay. They do have to document very well how this patient has requested another form other than written, if in fact that's the case. And then by the second skilled visit, the patient and or the representative have to also receive a verbal explanation of the patient's rights, and this verbal explanation has to be in the patient's language of choice. So if English is not their primary language, they have to get these rights in whatever language they choose. And we also have to make sure that we inform the patient that there is an interpreter available. Even if they choose to have a family member or friend be their interpreter, we have to let them know that interpretation services are available free of charge, and that they have the right to choose whomever they want to be their interpreter. So that's all I'm really going to spend a lot of time with patient rights and notification just yet. What I do want to show you here at 484.50C3, there are several points that are woven throughout woven throughout patient rights, comprehensive assessment, and plan of care. And the ones that I've highlighted here on this slide are some of those that are woven throughout the regulation. We see at the very first bullet point here that patient has the right to participate in, be informed about, and consent or refuse care in advance of and during treatment where appropriate. I want to pause just a moment and let you know that in the interpretive guidance and the regulations, CMS made a point to let us know that informed consent is not to only happen at the very beginning. You know, we're very accustomed to giving patients admission forms and having them signed. I'm sorry, I'm looking at questions, my bad. Having them sign that they understood and they received the patient rights and all of these different things is kind of an informed consent form. But what CMS wants us to understand is that that shouldn't just be a one-time deal. As care changes, or you're going to do a treatment, or you're going to do some kind of care, you have to make sure that patient has the right to participate in planning that care and knowing what's going on, and that they have the opportunity to say, yes, I want that to be done, or no, I don't want that to be done. And they point that out here in the regulation in advance of and during treatment. And they say with respect to completion of all assessments, the care that's to be furnished based on the comprehensive assessment, in establishing and revising the plan of care, the disciplines that will furnish the care, the frequency of visits, the expected outcomes of care, including patient-identified goals and anticipated risks and benefits. Just wanted to emphasize that the patient does have the ability to consent to these things from the very beginning. And when we go over to 484.50C5, what I want you to see is that the patient has the right to receive all the services that are outlined in the plan of care. So really what we're seeing here is that these patient rights, which we know CMS protects very strenuously, the patient actually has the right to get all the services on the plan of care. And as we've talked about in our morning meetings here at Axxess, these are things that really we've always done. We've always made sure the patient was receiving the things that were on the plan of care, but CMS has now tied these to actual standards, and these standards can be cited as condition level standards now, and CMS is basically trying to have agencies self-regulate rather than CMS and the surveyors having to come in and follow marginal agencies and continuously reprimand and follow up and reprimand and follow up. They've put that burden now on the agencies to self-monitor the quality of care and what they're doing, and if this is not being done, they'll come in and actually fine you. Now, one word to know about that: since we don't yet have the final interpretive guidance, CMS has come out and let us know that they're not going to be giving us fines and penalties the first year if we're not meeting the COPs. They will still cite you, but the civil monetary penalties will not begin until a year after implementation, unless they change that. So you've got a little bit of wiggle room and leeway to kind of have a learning curve to make sure you're doing all of this without getting fined. You will still get cited, however. So again, all of that not to scare you, but just to help you understand that we've got to tighten up what we do and make sure it is documented so that we can prove we're doing this stuff. I had another question come in. Are the interpretation services billable? No, they are not. As the COP regulation says, we have to provide those interpretation services free of charge, and that is not a billable service. It is something that we as agencies will have to, reading the follow-up. And by billable, you're referring to submitting claims for this service, not billing a client. Yeah, exactly. So you can't bill the patient or CMS for the interpretation services that you have to provide while you're caring for this patient. Very good questions. All right, let's move to the next piece. We're going to get into the content of the comprehensive assessment. And what I want you to watch for is how we tie in some of the regulations that are in the patient rights, which we know are very protected. And now we see this flowing into our comprehensive assessment. Now, when you're thinking about the comprehensive assessment, we're not just talking about OASIS items here. We're talking about the head-to-toe patient assessment. And this comprehensive assessment is really your foundation for building your plan of care. You have to do a very thorough patient assessment, and not just patient, but also their environment. What are their living conditions? What is the support system the patient has? What is their financial setting? What is their level of education? What kind of learner are they? Are they more visual? Are they more auditory learners? All of this information are pieces that we'll put together like a puzzle to form our plan of care. And so CMS has given us regulation here that tells us that part of that comprehensive assessment should include the patient's current health, their psychosocial, functional, and cognitive status. Now the psychosocial, that's what we were just talking about. Are they coping well? Do they have anxieties? What is their financial status? Have they finished school? Were they a college graduate, or were they unable to finish high school? Do they have a spouse who's, taking care of them, or are they widowed? What is their support system like? Are they able to get out and be social? Or are they stuck at home all the time, which can lead to depression and so on? They want us to really document what's going on with that patient from a psychosocial aspect as well as their functional status. And then we also see cognitive status here as well. They want to ensure that the patient's cognitive status is well assessed so that we can document whether or not that patient has the ability to learn what we need to teach them to take care of themselves. And if not, who is identified as being that person who can be taught and learn how to care for this patient. We see that the comprehensive assessment must also include the patient's strengths. That would be things such as they have better financial resources perhaps than the average patient, or they're motivated learners, or they have a higher education level, or they have a family member who's diabetic and they're also diabetic, so they already know how to do a glucometer check. Those are the kinds of things we're talking about here with patient strengths. We also have to document the patient's goals and their care preferences, and any information that can be used to demonstrate that patient's progress toward the achievement of goals identified by the patient and the measurable outcomes identified by the agency. Just a word to note on care preferences. CMS has told us in interpretive guidance that when they're talking about care preferences, literally, if the patient chooses to have a shower in the morning, we should do everything that we can to facilitate that shower in the morning. If that's one of their goals and it's not a safe goal, you've evaluated their ability to get in and out of the shower and it's very unsafe and high risk, then there needs to be a conversation with that patient and the patient's physician and or the caregivers that tell them, that might be a long-term goal, but for now, we really need to focus on XYZ so that we can make that happen. And that should be well documented in the patient's chart as well. But we have to think about that patient's care preferences, which is also one of their rights, by the way. We see that the comprehensive assessment must also contain the patient's continuing need for home care, the patient's medical, nursing, rehabilitative, social, and discharge planning needs, and then a review of all the medications the patient is currently using in order to identify any potential adverse effects and drug reactions, including ineffective drug therapy, significant side effects, significant drug interactions, duplicate drug therapy, and non-compliance with drug therapy. Let's take and pick these apart a little bit. The continuing need for home care. Again, why does that patient need you in the home as a skilled professional? There are hundreds of people coming out of facilities every day who have the same illnesses and diagnoses that we often get on referral. But what we need to really be documenting is, what is it about this particular patient's needs that warrants skilled services? Why do they need physical therapy? Why do they need skilled nursing care particularly? And not just a blanket statement like they have CHF. Okay, there's lots of people who have CHF who don't need home health. So what is it specifically about this patient that they need home care? And the new updates that we have in Agency Core will give you prompts so that you remember to document this information. All right, we also want to talk about discharge planning needs. Again, part of that comprehensive assessment and care planning is thinking about discharge from the very beginning. And I don't know about you all, but as long as I've been in home health, that's a concept that was always taught to me, that you're planning discharge from the very beginning. Home health was never intended to be custodial care. It's really intended to get in there when the patient has an acute episode that they're getting over, and you're teaching that patient how to manage their health to prevent further acute episodes and keep them out of the hospital and help them manage chronic comorbid conditions as much as possible. And then you've got to coordinate that with their physicians, their primary care physicians and other physicians that are involved. Well, that has always been the theory of home health, but as we talked about earlier, that's not always been the practice, especially when you look at documentation. So again, this is now tied to regulation and standards that we can be cited for, so we're going to have to be very careful about documenting that we're doing all of these things and putting this in our comprehensive assessment. And again, this is not just to be done only at start of care. Remember, comprehensive assessments happen at several different periods. So every time you're doing a comprehensive assessment, you're going to need to be addressing these things as well as that patient's progress toward the goals that you've already met. The patient's primary caregiver and any other available supports, including their willingness and ability to provide care and the availability of schedules, also needs to be in the comprehensive assessment according to our new COP guidelines. And then we must also document in the comprehensive assessment that patient's representative if they have one. Now, I want you to realize that each setting, whether it be home health, hospitals, acute care facilities, long-term care facilities, skilled nursing, outpatient, whatever, each of those settings have their own sets of conditions of participation or conditions of payment. And many of those settings have some of the similar standards that we do, especially when it comes to caregivers and legal representatives and all that. I say all of that just to let you know that when we have our new patient form, our patient intake form, you have the ability to go ahead and ask your referral source for that information, such as who their primary caregivers are, who's been involved with that patient's care at the hospital, and then you have the ability to reach out to those same persons and find out if they're going to be involved when the patient goes home, or if that was a temporary thing, and you can start planning this patient's care from referral. You don't want to wait until that clinician is in the home trying to figure out all of this and get the assessment done as well. As much of this as you can find out up front and document, the better off you're going to be, and you're going to really be showing that surveyor that you've put some time and thought into making this happen. Once the clinician gets out then in the home, they're able to assess that primary caregiver's availability and schedules and their willingness and ability to take care of the patient and their needs, and then document that in the record as well. Again, there will be prompts throughout the updates to Agency Core to help you remember to document these things, but it will be up to you to actually put the information in, right? There's only so much we can do on our end, and then we want you to be educated so that you're understanding what you need to document to fill in the blanks for CMS. All right, the comprehensive assessment must be updated and revised as frequently as the patient's condition warrants due to a major decline or improvement in the patient's health status, but not less frequently than the last 5 days of every 60-day period, and that count begins with the start of care date. Also within 48 hours of the patient's return from a hospital admission or at discharge. Those last 3 points haven't changed. Those are timelines that we already have to meet in order to update our comprehensive assessment. We know that last 5 days of every 60-day period we have to do a reassessment for recert. Within 48 hours of the patient's return from a hospital admission, we know that we have to do a resumption of care. And then at discharge, we also have to do a discharge oasis. Now, what's new again, and I say that because this is something that we used to do when PPS first came about for home health, prospective payment system. We were told at that time if we had a significant change in the patient's condition, it was something that was unanticipated and they got much better or much worse than they were when we first did our assessment and formed our plan of care, that we would have to go in and do a follow-up assessment, which is another type of oasis. And that follow-up oasis would be used to alter the plan of care and to alter the payment for that episode. Well, as PPS evolved, the follow-up assessment no longer changed our payment mid-cycle. That ended up being changed at the end of the episode when we sent our final bill. So many agencies got away from doing follow-up assessments because it didn't change their payment. And they would write supplemental orders as needed only as a way to update the plan of care. What we see at 484.55D is the reintroduction of that follow-up assessment. We see that we will have to conduct a comprehensive assessment as frequently as that patient's condition warrants due to a major decline or an improvement in that patient's health status. So if you see something changing with your patient that is significant enough that is going to greatly alter your plan of care, I suggest you go ahead and do this follow-up assessment. It still will not generate a change in your payment, but what it will do is give you the ability to generate a new plan of care that can be sent to the physician who's doing care plan oversight for signature. Just to clarify the functionality of that is whenever you are in the agency core system now, we have updated it so that follow-up assessments and resumption of care assessments will generate a new plan of care for you that you can send for signature. All right, the plan of care. Let's talk about that for a little while. Now, this is not, again, all-inclusive of all of the contents of the plan of care, but we are going to highlight those parts that, again, are flowing over from patient rights and from the comprehensive assessment and now into that plan of care. We see that the patient has to receive the home health services that are written in an individualized plan of care that identifies patient-specific measurable outcomes and goals. Now, I want you to pay attention to how many times you see in the next few slides the words individualized plan of care or patient-specific measurable. That is something that CMS has highly emphasized over and over. These plans of care cannot be cookie cutter plans of care anymore. We're not looking for blanket statements. We're looking here for individualized plans of care, patient-specific outcomes and goals, measurable goals. All of those things will have to be revised and updated by you as the clinician in the field to make sure that you're zeroing in on, during your assessment, as we talked about earlier, what is it particularly about this patient? What is it that they need particularly? And then documenting that, and that will flow over to your plan of care. We see that the mental, psychosocial, and cognitive status that we just saw in the comprehensive assessment is now part of the plan of care standards. So that's going to have to flow over on your plan of care as well. And then the last bullet point here, we see a description of that patient's risk for emergency department visits or hospital readmission and all the necessary interventions to address that underlying risk factor has to be included on your plan of care. So I want to stop just a moment and talk a little bit about the plan of care itself. Most of us, when we talk about a plan of care, we think about a 485 form. What I want you to understand is that because the 485 is no longer a CMS supported document, which means they don't update the 485 as formats change and regulations change, that 485 has primarily become obsolete. Well, pretty much it has become obsolete. Because there are no indicators, there's no places to put information such as the psychosocial or cognitive status or the hospital readmission risk and all of that. So for that reason, we here at Axxess have designed the plan of care to not be a 485. It's going to look very similar to a 485, but what we've done is actually give you the indicators and locators for all of these additional requirements such as psychosocial and cognitive status, your hospital readmission, and so on, so that they're easily found by whomever's looking at this plan of care. But I just want you to understand it's not going to be a true 485 plan of care. The certification statement, for example, that's normally in indicator box number 26 on a 485, that is going to be something that you can choose to put on your plan of care or not. And in order to make that certification statement flow over to your plan of care, at the end of your OASIS assessment, you're going to look for a box or a button that says include the certification statement on the plan of care. And if you fail to do that, it's not going to flow over to that plan of care. Now, the functionality, once you've done that, you will still be able to amend that certification statement and make sure it's compliant by adding, for example, that the face-to-face encounter occurred and what day that occurred on. But that's something that you will still be needing to do on your end. We didn't write those out standards because they're not standard for everyone. And I think we have a question that's come in. Give me just a moment here. What happens if the discipline does not complete the comprehensive assessment in 5 days? Okay, well, let's talk about that. Ms. Shawn's going to tell you about the functionality aspects of that this afternoon. But as far as compliance aspects, let's talk about what happens if you don't complete your comprehensive assessment in 5 days. Now, we have all heard about a 5-day window. And remember, the completion of your comprehensive assessment is different from start of care to recert and resumption of care, by the way. You don't get the full 5 days at every time. Sometimes you only have 48 hours to complete that assessment, okay? But for the 5-day window, we're talking about a start of care assessment. CMS tells us that we have 5 days to complete the assessment. And what they mean here is not 5 days to finish filling out the form. That 5-day period is given to you as a grace period to ensure that you are able to communicate with the physician to clarify things that you might need clarification on. For example, if you find medications in the home that don't match your discharge medication profile from the hospital, you have 5 days to try and reconcile those medications and get that information together. Or if you need to clarify a diagnosis, or you need to reach out to a caregiver and find out when they got the flu shot. That's what that 5-day window is for. It's not just giving you 5 days to complete your documentation. So what happens if you don't do that? Basically, you're not going to be in compliance. If you're taking 7 to 10 days later to finish this OASIS or finish calling physicians and getting that information, you're not going to be in compliance as far as CMS is concerned. So anyway, you're going to have some functionality changes within the system. Sean's going to go over that this afternoon, but I just want to let you understand that when we start doing things like shoring up the window of time that you can add to a comprehensive assessment, again, that's not just something that we're doing here at Axxess to be a pain. It's to make you or remind you or help you to be compliant with the COPs and the Medicare guidelines. So again, you'll find the information if you're looking more about this comprehensive assessment and the timeline. You're going to find that in your OASIS C2 guidance manual. And also when you go to the QEIS website and you click on and search for the OASIS questions and answers that come up quarterly, you'll see that this has been brought up throughout all of those Q&As and OASIS guidance where they're talking about completing that assessment. And just so you know, the start of care date counts as day 0, and then the next day starts as day 1, day 2, day 3, day 4, day 5. So basically you have 5 full days in addition to whatever partial amount of time you have on the start of care date, okay? The next question, do we have to export a follow-up assessment to CMS? The answer to that would be yes. You would need to export that follow-up assessment, and you would also need to make sure that that's done in that 30-day period like all other OASIS that have to be exported. When you do a follow-up OASIS for significant changes, do you need to export it to CMS? Yes, that's a very good question. We've had a couple people ask that. Will the risk assessment, the risk for emergency room and hospital readmission, be part of the assessment and Axxess form? Yes, you will see that in the functionality webinar this afternoon, but as part of your comprehensive assessment, you're actually going to have 2 different hospital risk assessments to choose from, and your agency policy will dictate whether or not you're going to do one of those or both of those. So again, you're going to have to look at the functionality here, update your policies and procedures, and make sure you're instructing your staff members on how to handle. The next question, how far in advance can we give the patient's rights to the patient? CMS doesn't tell us how far in advance you can do it. They just say that it has to be done let me say that differently, that it has to be done at least by the initial assessment or during the initial assessment and before care is rendered. So you have to make sure it happens before you do any kind of teaching or hands-on care or even collecting vital signs for that patient. You have to give them their patient rights. But as far as how far in advance, CMS doesn't tell you that, okay? They're going to let that be an agency decision. All right, I don't see any other questions just now, so we're going to keep moving. We're still talking about our plan of care here. The individualized plan of care must include the following: the patient and caregiver education and training to facilitate a timely discharge, patient-specific interventions and education, and then measurable outcomes and goals identified by the agency and the patient. Again, remember, we're including this patient more. We've tried to find out what their goals are. We want to hear about their care preferences, and now we're seeing that in the plan of care, we have to also identify those goals that the patient identified and make sure that flows on the plan of care as well. Again, you're going to see that in functionality in the agency core product when you get in there and do your assessment as well. And then the plan of care also has to have information related to any advanced directives on the plan of care. We are pretty much accustomed to putting DNR orders on the plan of care, but now we're going to see any advanced directives flow over to your plan of care as well. Now, I want to take a moment on this slide to really get into this first bullet point. We've kind of just talked about it in passing in the prior webinars that I've conducted, but because of the amount of questions that have come into Agency Core headquarters up here at Axxess, I want to take a minute and just talk about this bullet point a minute. At 484.60A, the plan of care, it tells us all patient care orders, including verbal orders, must be recorded in the plan of care. So basically, if you have an order that affects the patient's care, any kind of verbal order, they have to be recorded in the plan of care. I understand we had a customer that had a little bit of a question about this yesterday, who, because of our functionality, had a concern about the orders, that everything didn't have to be on the plan of care. I want to highlight at 484.60A3, this is where it tells us that all verbal orders, all patient care orders, they have to be recorded on that plan of care. That's where you heard the terminology. If you've been paying attention and following COP this last year, you might have heard the terminology about an evolving plan of care. And what that simply means is that this plan of care is a living document. It's not just a document that we create at start of care and then again at research, but it's constantly changing and evolving. The plan of care should have tweaks, and normally it does. We often see this done before these COPs and prior practice. We would have a growing list of supplemental orders. And if I, as the clinician in the field, wanted to see what the most recent orders were, I would have to dig through that patient's chart and read all the supplemental orders. What we're seeing with this evolving plan of care or this living plan of care is that as these orders come in, this plan of care is going to update and change. And for those of you who are on the line who worked in hospitals before, on the nursing floor especially, back in the day when I started nursing, we had what was called a nursing cardex. That cardex was literally a card of orders that stayed on the nursing floor, and as the physicians would make rounds and write new orders, that cardex would be updated. You would have to erase the orders that had been discontinued and then pencil in those orders that had just been left on the chart. And that way, no matter which nurse or whomever wanted to see what was going on with that patient, they knew that there was a central location to go and see all of the patient's orders without having to dig through those old paper charts that we had on the floor at the time. Well, of course, technology has changed. We now embraced EMRs, and at the hospital, the EMRs have done this automatically for many years. We see finally that in home health, this regulation has come about, and now with our EMR systems for home health, we also have to have the same concept, that the plan of care needs to be referenced, and that it, no matter who's looking at it at any time, they're getting the most current orders. Now, that's going to be very dependent on the timeliness in your policies as far as when orders are created and written. Part of that in the standards for the COPs is that all verbal orders must now have a timestamp and a date stamp as to when that verbal order was received. So for those reasons, what you're seeing is CMS pretty much telling us you're not different than any other setting. You have to record orders when you get them, and those orders have to be included in your plan of care so that everyone taking care of this patient, they're able to follow the physician's orders. And so for that reason, you're going to see the functionality change, including this evolving plan of care. Ms. Shawn will go over that again this afternoon, and if she doesn't get to that this afternoon, it was definitely in one of the prior sessions that has been recorded, where we talk about how those orders flow over to our new plan of care and the new plan of care summary. The individualized plan of care has to be reviewed and revised by the physician who's responsible for the home health plan of care, and the agency must promptly alert the relevant physician or physicians to any changes in that patient's condition or needs that suggest the outcomes are not being achieved and or that the plan of care should be altered. And again, this is something that we've always done. We just might not have documented it properly, and now it's tied to a standard to make sure that this is reflected in the patient's chart. So basically, for example, if you're out seeing a patient with a wound and you notice that that wound care treatment is not helping that wound get better, you're not seeing granulation, you're not seeing any changes in the wound bed, that would let you know that this outcome's not going to be achieved, perhaps, with the treatment that we have. And I need to alert the relevant physician or physicians to any changes that that patient's condition or needs have that suggests we need to do something differently. So maybe you've got a wound care physician and you have an endocrinologist, and you're noticing that not only is this wound not getting better, but you've got blood sugars that are running between 2 and 400, and you know that that's going to slow wound healing. So you're going to have to make sure it's documented that you have promptly alerted those relevant physicians, your endocrinologist to see if you can get the blood glucose down, and then also the wound care physician to see if we can change the treatment. And so those communications need to be documented in the chart, as well as what was done about the problem that you identified. And then if you receive verbal orders, those would be recorded, as well as the time and date that you took the verbal order. And then those verbal orders will flow into this evolving plan of care, so that no matter if the LVN goes tomorrow, they're going to be able to see exactly what you're seeing reflected in that plan of care at any time. All right, I've got another question that's come in. This goes back to our follow-up assessment. It says, if the payment's HIPS code changes when we do the significant change in condition follow-up, will it have an impact to our final billing? The answer to that is that the billing aspects will not have changed as far as what I've read so far, okay? Basically, no. The SCIC, or the follow-up assessment's not going to generate a new HIPS code. Again, that's going to continue to be done when your final bill happens. As it stands now, what impacts your final bill is the number of therapy visits that you have at the end of the episode versus how many you anticipated at the beginning. Okay, so that process is not going to change yet. I anticipate what will happen will be that sometime in the future, we've heard about this home health resource grouper, the new grouper program and 30-day episodes. At some point in the future, we're going to be doing 30-day episodic billing. That got postponed. It was supposed to have happened in 2019. CMS, because of all of the comments that they received on the HHGM, or home health grouper model, decided to look into it further and put that off a little bit longer. But we do know that eventually that's going to happen. So for right now, the SCIC, or the follow-up OASIS, is not going to change your billing. It will be what happens on that final bill that's going to change it. The next question. Do we need to send the updated plan of care to the physician for signature every time we get a new order, a new verbal order? So we get this question a lot, and so basically what we know here from what we've learned in the draft interpretive guidance, and we're still waiting on final guidance to give us some clarity on this, but basically, okay, we'll get to that question in just a moment, but basically with your changes in the plan of care, when you have a verbal order, those verbal orders must be sent for authentication and signature. So those signatures will suffice as authentication for the plan of care change. But when you have a major plan of care change, let's say that on the example we just talked about a minute ago, if the patient's blood glucose is running between 2 and 400 and their wound is not healing, so the endocrinologist gives you an order to increase metformin to 2 500 milligram tablets twice a day. You're going to record that verbal order, and you're going to put the time that you took that verbal order. So maybe you got that at 10 o'clock in the morning, and you finish your visit at 11:05, and then you record your verbal order. At 11:05, you're going to put that you received that at 10 o'clock in the morning. That was the time of the verbal order, okay? Now, those orders are going to flow into that revolving plan of care, or evolving, I should say, not revolving, that's a door. The evolving plan of care, but you don't have to send that whole plan of care for signature. You do have to communicate all the changes to the physician. And some agencies' policies may be that they want to send that plan of care every time and have it signed as validation that actually happened. But again, that's going to depend on your agency and your policies. CMS does not require that you send the plan of care every time you get a new verbal order, because the verbal order itself is going to be authenticated by the physician. Now, we're going to get into this in just a moment under coordination of care, but you do have to make sure that all the physicians who are giving orders toward that patient's plan of care are notified of any changes in the plan of care. Notice they say notified. They don't say that you have to have them sign for that. So again, that's going to be an agency decision and an agency policy. Personally, I'm not going to be sending out that many documents for signature, because if I can't get those things signed, I can't bill my final bill, because I can't do that until all the signatures are back. So I'm not going to go over above and beyond unless my accrediting body or my agency policy says that I have to send the plan of care every time and have every physician sign it as proof that we communicated to them. I'm personally not going to do that, but that's a Jennifer opinion. Please know that is not guidance, okay? Do we need to complete a follow-up assessment when there is a change in the wound treatment? Again, if it's an unanticipated change, if it's something that you did not see coming when you did your last assessment, then you would need to do a follow-up assessment. They get a whole lot better or a whole lot worse, then you would need to do a follow-up assessment. So just every time you change the wound treatment, if you anticipate this wound is maybe not going to do so great, and you've documented that in your comprehensive assessment at the beginning, that you notice there's some risk factors, their blood glucose is out of control, they're more sedentary than they should be, whatever other issues that you've documented, and then that continues to be the case and the wound worsens, I don't think that warrants another follow-up assessment. But for example, if the patient you didn't see it coming, they've been doing really great with their blood glucose, they know how to monitor it, they can verbalize all about the diet, and then all of a sudden something happens and that blood glucose goes completely out of control and this wound deteriorates all of a sudden, and you've got to change everything up. Maybe they have a TIA, or I don't know, the caregiver changes who's been checking the glucose, you got to find somebody else. Those are more extreme things that you could not anticipate. That's when I'm thinking about doing a follow-up assessment there. The next question we have, are PT/INR orders, including Coumadin adjustments, considered a significant change, and would they require a follow-up assessment as well as generating a new plan of care? Again, you would think with PT/INRs and Coumadin, that's something that we anticipate frequent changes. For that reason, for those issues alone, just for the PT/INR Coumadin adjustment changes, I would not do a follow-up assessment for that. Again, we're talking about unanticipated changes. The patient gets a whole lot better or a whole lot worse. That's when you need to do your follow-up or your SCIC. And then the last question that's come in, will the evolving plan of care capture new orders according to date on the orders in case of late entry orders? My understanding is that the software is going to go by the date that you recorded that order, not the date that you received it. Because it's going to be hard to sequence and resequence things that are not happening in sequence, if that makes any sense. So again, remember, when you think about the whole reason why all of these changes are coming about with the COPs, CMS is trying to ensure safe, quality care. So the best practice to make sure the patient gets safe, quality care is to record those verbal orders when you get the very first opportunity to do so. If I'm getting that in the middle of a patient visit and I'm doing wound vac, I might not stop and record it right there in the middle of my wound vac treatment. But if it's in the middle of a teaching session and I have the opportunity, I want to record that verbal order just as soon as I possibly can. Because number one, the accuracy of that order is increased the quicker that you write it. And number two, for safety sakes, the quicker that you record that order, that means that other people are going to be able to see it, it's going to get processed, and those orders can be followed. And if that's not the case because you're not timely with your verbal orders, then we're going to have an issue, because that's going to be a patient jeopardy safety issue and a compliance issue. And I like to remind people when I'm out on the road teaching and doing seminars and stuff live, remember, we seem to think that home health is different than all the other care settings. And we are unique in certain aspects, but as far as how we practice our professional degrees and our professional skilled services, that's not different just because we're in home health. You certainly couldn't get away with writing a verbal order in a a hospital or a assisted living facility or a skilled nursing facility 3 or 4 days later. You'd get in all kinds of trouble. You get your license suspended in the whole 9 yards. So again, I'm not trying to be preachy. I'm just trying to help you understand the brevity of these regulations and the whys. For patient safety reasons, you've got to record those immediately. And if that's not done timely, then it's not going to flow onto your plan of care timely, which means that the whole reason for doing this evolving plan of care, we've just made that obsolete. Okay? I hope that answers your question and helps you understand a little bit. The individualized plan of care, we've talked about that. The physician has to sign that when you have a plan of care generated, a new one. Mostly that's going to be at start of care. Of course, when resumption of care happens, that plan of care will be generated. That can be sent to the physician who's doing care plan oversight for signature. Also, at your significant change or follow-up assessments, those are going to generate a plan of care change that you can send for signature. And then also recert. All right, I've got another question here. The plan of care replaced the 485, and that has to be signed within 30 days. Don't you think it's redundant since all verbal orders are already signed and authenticated? All right, I hope I'm understanding your question well, but I'll answer that as much as I can. So, yes, the plan of care, remember, we're not changing the plan of care or replacing it. We're just changing what we're calling it. The plan of care has always been a plan of care, and the plan of care basically is where you record all of the verbal orders for care for this episode. A lot of us sometimes think about that plan of care as something other than physician orders, but when you truly understand the plan of care, even the diet, all of those things, those are doctor's orders. That's why you have to show coordination of care, that you actually spoke with the physician when you're creating the plan of care, because we can't order things as skilled professionals. We don't have the ability to order any care for the patient. That's a physician's duty as part of their practice act and not ours. So for that reason, this plan of care is just a document that reflects all of the orders that we've received from the physician. We're just calling it something different. The 485, by the way, got its name because it was created in April of 1985. That's how creative our government is. But we got used to calling it a 485 when really we should have been referring to that as a plan of care all this time. So what we've done, we've not really replaced the 485, we've just updated its format, and in both cases we're talking about a plan of care. So according to policies, usually it's going to be state policy, yes, they must be signed within 30 days or less. Do I think it's redundant? Remember, verbal orders, if you didn't have a plan of care and all you had was a stack of verbal orders that you had to dig through every time you provided patient care, that would be so cumbersome it would not be safe for the patient. And so that's why CMS has set up the system where you have verbal orders that you have to record, send those for signature to authenticate that, yes, the doctor did actually verbally give me this order, because again, I can't just write orders willy-nilly, and then that's going to flow over to a plan of care. That's that kind of like that Cardex back on the hospital floor, that one central location that all of us professionals can go and look and see what the care is for that patient. And that's to help ensure, one, that the patient's getting safe care, but also that we are following the physician's orders, which can affect our licensure. And I don't know about the rest of y'all, but I don't plan to lose my license because my colleague here didn't write an order that they should have, and I didn't follow that order, and then they want to come back and say, well, that's not what the doctor said. Okay, well, that's not what was in the chart when I delivered the care, so that's on you and that's not on me, right? Those are the kinds of things that CMS is talking about here, avoiding by making sure we're documenting timely, that it's getting updated in the record timely, and that the orders are followed as they are given by the physician, and that we as professionals are following the doctor's orders. Okay, let's see, we have one more question. Since the new PT evaluation is embedded into the new OASIS PT, do we still need to schedule a separate PT eval? That's more of a functionality question, but I will go ahead and address that. Basically, you're talking about in the agency core system, before we upgraded for the COPs, when you did a start of care PT or a PT recert, you would have had to schedule the OASIS and the PT evaluation separately. We've now incorporated those into one OASIS form that has the assessment and the evaluation together, so you do not still need to schedule those as of the 13th of January going forward. You would just schedule your PT OASIS. Okay, let's get back to our presentation. We're getting really close on time. It's already 11. I'm not even kind of halfway through, but we're going to go ahead and stop soon anyway. You can refer back to these presentations that have been presented before, but let's at least finish the plan of care and see how quickly we can get through the rest of these slides just for documentation's sake. And then if you have to get off the line, remember you can go to Axxess.com, look for our on-demand video content, and these sessions will be posted Axxess.com/help as well for our help center. All of these videos will be posted and you can listen to them whenever you have time as well. Okay, so they're on demand for your ease of use and so that you have the flexibility to listen to them whenever you have time. The revised plan of care has to reflect current information from the patient's updated comprehensive assessment and contain information concerning the patient's progress toward those measurable outcomes and goals identified by the agency and the patient in the plan of care. And then any revision to that plan of care due to a change in patient health status must be communicated to the patient, the representative if they have one, the caregiver, and all physicians issuing orders for that agency plan of care. We've talked about that already in the webinar today. Whenever those plan of care changes happen through the supplemental order, remember you already have to be giving the patient, or you should be already, it's already regulation that when a change in treatment occurs that you're already supposed to be doing home health CCNs and ABNs. Where the patient is notified of changes, especially if you're changing a frequency or taking away supplies that you had been providing to that patient, or you're changing what you're giving the patient that's different from what you told them up front. We are already supposed to be getting these government mandated forms signed and documented in the chart anyway. So this is just going to be an additional level of making sure that we're also communicating with the physicians who are giving orders to the plan of care, as well as that patient and their support system, their representatives, their caregivers, and so on. Coordination of care is next at 484.60D. The agency must assure communication with all the physicians involved in the plan of care. Again, it's right there in black and white. You've got to communicate with all the physicians who are giving orders for this plan of care. We don't want the patient to be in a silo and the physicians not knowing what's going on and ordering things that are counterintuitive to the progression that we're trying to do in the outcomes. So we have to communicate with all those physicians involved in the plan of care. And then we must integrate orders from all physicians involved in the plan of care to assure the coordination of services and interventions provided to the patient. We must integrate services, whether those services are provided directly or under arrangement, to assure the identification of patient needs and factors that could affect patient safety and treatment effectiveness, and the coordination of care provided by all disciplines. The main takeaway point here with the coordination of care is just to understand that CMS is basically coming right out and telling you it does not matter what your employment status is. If you're working in home health, whether you're directly employed by the agency as a full-time employee or a part-time employee, or you're working PRN, or whether you're working as a contracted discipline, that you still are responsible for coordination of care and for making sure that you're identifying patient problems and communicating that to the physician when they arise, and then making sure that you're giving safe and effective treatment. Doesn't matter your employment status. The agency must coordinate care delivery to meet the patient's needs and involve the patient, the representative, and the caregiver as appropriate in the coordination of care activities. Again, remember, we're thinking about a patient-centered home here, and that the patient is the center, and the communication, there's a big chain of communication that has to happen when things are going on with the patient, and we're coordinating care delivery. We have to involve the patient, the representative, and the caregivers. So if they got a caregiver that's paid help coming in and giving the bath, and we know that physical therapy is going to come in right after that bath time, and we don't want that to happen so the patient can get the full benefit from the therapy treatment. We need to try and coordinate with that caregiver to find out what time bath time is, and then schedule that PT visit at a different time after the patient's had an opportunity to recuperate from the bathing process. That's kind of what CMS is talking about here. The agency has to ensure that each patient and his or her caregivers, where applicable, receive ongoing education and training provided by the agency as appropriate regarding the care and services identified in the plan of care. The agency must provide training as necessary to ensure a timely discharge. Again, we've talked about this already in the assessment of the patient. We see that this theme continues in coordination of care. We have to coordinate the care with the caregivers as well as the patient, and make sure that we're providing training to them as well to make sure this patient is timely discharged. At 484.60E, we see a new standard that appeared in the final rule on COPs that was not in the proposed rule. And this came about because in the proposed rule, CMS told us that they were going to have us leave a copy of the patient's plan of care in the patient's home. And several agencies wrote in concerned about that, saying, you know, that's great in theory, but the plan of care has so much information and so much of that's jargon that the patient really doesn't understand or doesn't need to know. I don't think we need to leave a whole plan of care. And CMS came back and said, yeah, you're probably right. The plan of care itself is kind of overkill, but there are certain pieces of information that the patient should have in their home, and this should be in written form so that they can refer back to it as needed. So the guidance at 484.60E tells us that we have to leave a copy of written instructions outlining the patient's medication schedule and instructions, the medication name, the dosage, and the frequency of the medications, and then which medications are going to be administered by home health agency personnel. In the written information to the patient, we see that any treatments that are to be administered by the agency personnel must be written and left with the patient as well. And when we're thinking about treatments, think about things like B12 injections, modalities from your therapist like ultrasound or percussion or whatever else, home exercise program. All of those treatments also have to be written with instructions to the patient as well. We see that we must provide them with a copy of any other pertinent information that's related to their care and treatments that the agency will provide, and then that written information needs to be specific to that patient's care needs. We must also provide the patient and caregiver with a copy of written instructions outlining the name and contact information of the agency's clinical manager. Now, some agencies may only have one clinical manager. Some of the larger agencies may have several. But what we see in the draft interpretive guidelines is that once that comprehensive assessment is completed, the documents mentioned have to be provided to that patient, and there has to be clear written communication between the agency and the patient representative that ensures that the patients and families understand what to expect. That's the whole reason for the written information, that they can refer back to this written information and know who's supposed to come and what they're supposed to do and understand fully what their treatment is. We see at the draft interpretive guidance regarding the medication profile that the med profile and what's written in the home is based on that patient's medication regimen review, and that the medication information has to be in plain language and should avoid using abbreviations. So you're not going to want to see in the home things like PCN for penicillin or ASA for aspirin. Now, Joint Commission has had us not doing abbreviations for a real long time, but if you haven't used an accrediting body and maybe you're just licensed and certified, this may be new to you. You're going to need to write out in plain language, such as penicillin, 1 capsule daily or 4 times a day, whatever, for 7 days by mouth with food or whatever. But it needs to be in plain language, and you can't use abbreviations in this written information about medications. As far as the clinical manager, the draft interpretive guidance tells us that the name and the phone number of that agency's clinical manager has to be provided. They're talking about the business phone number here. and that the clinical manager's email address may be provided as well if you want to, but you don't have to. And then the agency should explain when that clinical manager should be contacted for discussion about their services. Lastly, we're going to get a little bit into infection prevention and control, and then the responsibilities of the clinicians. I don't want to get into a lot of this, but mostly want to show you that the infection prevention and control now has 3 standards. One, you've got prevention, and that's where we talk about using universal or standard precautions. It's been updated to standard precautions. Hand washing, that we have to follow those standards of practice to prevent infections and communicable diseases. Then we see the control, where we actually maintain a coordinated agency-wide program for surveillance, identification, prevention, control, and investigation of infectious and communicable diseases, and that is part of our QAPI program. Now, the QAPI program itself has been overhauled, and we don't have time to get into that, but certainly if you go into the on-demand content on the COP series that I did, there's a whole hour session on QAPI program as the regulations have outlined it. But basically what they're doing, they want to make sure we're not just filling out infection control forms and turning those in, but that those are actually looked at and integrated as to our QAPI program, trying to figure out if there are any common denominators as to why these patients are getting infections, and if so, what we're doing about them to make sure that it doesn't happen. And then lastly, the one I really want to emphasize is 484.70C, education on infection prevention and control. We now have a COP standard that tells us that we must provide infection education to our staff, our patients, and our caregivers. And this should include appropriate use, transport, storage, and cleaning methods of patient care equipment. So not only the equipment that the patient has in the home, but that equipment that we're taking in and out of the patient's home. And then also if we go in the patient's home and see that they have blood smeared all over their glucometer, for example, that we're providing education as to the proper way to clean that equipment, how to wash their hands before and after doing care, making sure that their lancets and devices, lancets and strips is what I'm trying to say, they're not throwing these in the trash can, that they're using a puncture-proof container and so on, and that this education needs to be job-specific. It needs to have infection prevention education and training, and then processes to make sure that all the healthcare personnel understand and are competent to adhere. So we're talking about competency evaluations, basically, to make sure that the education sticks and that our staff members understand how to take care of equipment and so on. Lastly, I want to get into the skilled professional services at 484.75. Basically, CMS is telling us that if you're a skilled nurse, PT, speech-language pathologist, OT, or social work, that you must participate in the coordination of care. And it doesn't matter, again, what your employment status is. If you're a directly hired employee or you're a contracted employee under arrangement, that you must participate in coordination of care. Also, that the skilled professionals must meet the qualifications for that professional. Those qualifications are laid out at 484.115, and we're not going to get into that. But skilled professionals assume responsibility per the COPs for ongoing interdisciplinary assessment of the patient. So not just what you're seeing, but comparing your assessment with the other disciplines and what are they seeing, and that can be documented in the coordination of care that we just talked about. Also, with development and evaluation of the plan of care in partnership with the patient representative and caregiver. Each of us skilled professionals are responsible for that. And also for providing services that are ordered by a physician as indicated in the plan of care. Again, this is where that ties back to recording those verbal orders and making sure that plan of care is up to date. Because as a skilled professional, I am responsible for providing services only ordered by a physician as indicated in that plan of care. So if that order is not written, I can't follow that physician's order. I'm going to be liable if somebody's not doing that properly, right? Skilled professionals assume responsibility for patient, caregiver, and family counseling, patient and caregiver education, preparing clinical notes, and then communication with all physicians involved in the plan of care and other healthcare practitioners as appropriate related to that plan of care. Skilled professionals also assume the responsibility for participating in the Home Health Agency's QAPI program and participating in the agency's sponsored in-service training. Again, we're not just talking about full-time employees here. We're talking about all staff members that are skilled professionals. They are assuming responsibility for these different pieces of agency functions and professional functions. Again, those days of just going out and making a visit and doing some vital signs and documenting a halfway note and turning that in and hoping for the best, those days are gone. CMS is done with marginal agencies. They don't have the time and money to continue to provide oversight on an ongoing basis, and these standards are basically to put that responsibility on the agencies for us to self-monitor the quality of care that we're doing. Lastly, we see that the skilled professionals have to supervise the other professionals. For example, all nursing services have to be under the supervision of an RN. All rehabilitative services need to be under the supervision of an OT or PT, and all medical social services have to be under the supervision of a social worker. The contents of the clinical record must include the patient's comprehensive assessment, including all assessments from the most recent admission, the clinical notes, the plans of care, and the physician orders, all interventions and responses to those interventions, medication administration, treatments, and services. They must also include goals in the plan of care and then the patient's progress in achieving those goals. We have to have the contact information for the patient's representative, and the patient's primary caregiver. And again, we have prompts in our agency core updates to help you remember at the very moment of referral that you need this information. And if you have it, you can go ahead and record it then. And then we must also have the contact information for the primary care practitioner or other healthcare professional who's going to provide care and services to the patient after agency discharge. What that means here is if the patient identifies an attending physician who's going to resume care after the agency's discharged, then the contact information should be in that medical record, and it doesn't matter if this attending physician is the responsible or physician who is providing care plan oversight, in other words, or if it's someone else. The reason they want us to capture this information is so that we can give a discharge summary to this attending physician, letting them know what care we have done and how to continue to keep this patient out of the hospital, basically, coordinating that care. The record must also have a completed discharge summary. You'd be surprised how many records I review that do not have discharge summaries completed and the final bill is sent. This is now tied to a standard. You will get cited. You will get money taken back if this is not done. That discharge summary has to be sent to the primary care practitioner or other healthcare professional responsible after discharge from the agency, and we have to make sure that that's sent within 5 business days of the patient's discharge. Interpretive guidance lets us know that that date for the discharge summary, when it has to be sent, has to be done within 5 days, and the day that the order is taken to discharge is when that 5-day period counts. Your discharge summary typically includes admission and discharge dates, physician responsible for the home health plan of care, the reason for admission to home health, the types of services provided and the frequency of those services, and then lab data, medications that the patient is on at the time of discharge, the patient's discharge condition, the patient outcomes in meeting the goals in the plan of care, and then any patient and family post-discharge instructions. Remember, there's the draft interpretive guidance that tells us that DC summary is sent within 5 business days from the date of the order from the responsible physician for discharge. We also see that the records have to include a completed transfer summary, and that has to be sent within 2 business days of a planned transfer. So basically, if you're going to transfer the patient to a hospital and you know about this transfer, within 2 business days, that transfer summary has to be at the facility where the patient's receiving care. However, if you don't know about the transfer, it happens and the patient's back home, they're not receiving care anymore. When you find out, you don't have to send the transfer summary in those cases. The draft transfer summary, according to draft interpretive guidance, typically has the same information in it as the discharge summary. For authentication, remember entries in the clinical record have to be clear, complete, legible, and appropriately authenticated, dated, and timed. That's why you have activity logs. That's why you have, in the new functionality, you're going to see where in the QA Center, if I go in as a QA nurse and change something on Ms. Shawn's assessment, it's going to show not only Ms. Shawn's signature, but my signature as well, because of the changes that I've made. And you're going to hear more about that functionality in the webinar videos that are recorded, as well as possibly this afternoon's functionality webinar as well. Your authentication has to include a signature and a title or your occupation, or a secured computer entry by a unique identifier of a primary author who has reviewed and approved the entry. Again, unique identifier. Don't be sharing your usernames and passwords. That's what makes it unique to you. If you're giving that to someone else, they can go in and alter your documentation, and then it's no longer going to be an authentic entry. So I would encourage that you do not share that information, and that you frequently change your passwords as well. The last thing I want to go over today is retrieval of clinical records. Please note that the patient's clinical record has to be available to them on request. It can be a hard copy or it can be an electronic copy, but you have to provide it free of charge when the patient requests, and it has to be done by the next home visit or within 4 business days, whichever comes first. And this is just another prompt to remind you, this is another reason why this record should be up to date and your documentation needs to be in timely. Because if the aide's out there at 8 o'clock in the morning and the patient says, I want a copy of my records, and the nurse is supposed to go at 2 o'clock in the afternoon, you have to get that chart together and give it to that patient. And so all notes up until the time when they request their record, those need to be completed in that medical record. And so if we're not doing timely documentation, they're going to have a partial record, and that could get you into some legal trouble, especially if there's a legal reason they're looking for those records. I'm sorry about the fact that we rushed through the last part of that, but hopefully you got everything that you need. If not, certainly you can email or give me a phone call with any questions that you might have. My phone number and extension is here on the screen that you see. My email is jgibson@axxess.com. I'm always happy to help you any way that I can. And then lastly, don't forget about our Help Center, our on-demand videos, and our YouTube channel as well. All of the videos that we have done will be uploaded into these various places, including recordings of the webinar series that we've done the last week, the whys in the morning and the functionalities in the afternoon. We do have one remaining live webinar this afternoon for questions and answers on the functionality of agency core with Ms. Shawn Hamilton. That will happen at 3 o'clock. Make sure you sign up for that if you haven't already. And then certainly feel free to go on to Axxess.com and look for our on-demand videos or our Help Center, or go to our Axxess YouTube channel for more information. As always, I want to take a moment and just thank you for what you do every day in your agency. We certainly know that there are patients at home who wouldn't get the care that they need and deserve where you're not there to do your job every day. So if nobody else thanks you for that, just know that we thank you here at Axxess. We appreciate what you do, and we're here to support your endeavors. So just give us a shout anytime you need something. We'll be glad to help you. Again, this is Jennifer Gibson. I hope you have a fabulous day, and we hope you can join us again soon. Thank you so much. Bye-bye.